When I was 11, my brother was born prematurely, and I watched a surgeon save his life. Since then, I've wanted nothing more to become a surgeon. More specifically, I want to be a trauma surgeon. Good afternoon, my name is Bethany OW, and this year in ISM, I am studying general surgery with the subspecialty of trauma. I understand this is a very difficult path to venture upon. However, in the words of Confucius, choose a job that you love and you'll never have to work a day in your life. General surgeons who specialize in trauma focus the majority of their attention on emergency situations. The most common injuries that trauma surgeons operate on are gunshot wounds, car accidents, and knife punctures. These are very difficult things to encounter, much less operate on. So this year I took ISM to gain a better understanding of not only how the body functions, but also what it takes to become a trauma surgeon and work in these high-pressure situations. In order to broaden my understanding of trauma surgery, I conducted 5 interviews with surgeons who specialize in the field. The first interview that I conducted was with Dr. Abdel Fattah. Dr. Abdel Fattah is the Associate Professor of Surgery in the Department of Trauma and Critical Care. One of the main things that was brought up in every interview was that Parkland was a county hospital, meaning that every kind of person with any background could come in. Due to the area where Parkland is located in downtown Dallas, many of the patients are undereducated and may not have insurance. But he actually said that the ability to treat everyone and take care of everyone is amazing, no matter their background. My second interview was with Dr. Christian Minshaw. Dr. Minshaw is the Chief of Surgical Critical Care as well as the Director of Burns and Trauma at Parkland Medical Center. He really opened my eyes to see how trauma surgeries run the show in a way. They do this because they're not boxed into one specific specialty. When a polytraumatic patient comes into the ER, it is not only the trauma surgeon's duty to treat the general aspect of the trauma, but they must also know every other part of the body and be able to operate on it. He also explained not to rush in life because no matter how fast you get to become a surgeon, everyone's going to get there in the end if they're aiming for that. My third interview was with Dr. Maureen Finnegan. Dr. Finnegan is the Director of Orthopedic Surgery and Orthopedic Trauma Surgery. Dr. Finnegan is the only trauma surgeon who I interviewed that was 1, a woman, and 2, an orthopedic trauma surgeon, instead of a general trauma surgeon. The difference is that a general trauma surgeon, an orthopedic trauma surgeon works mostly on the aftermath of surgeries. So when a patient comes into the ER, a general surgeon is the one who meets them and does the surgeries. The aftermath is when they go to the orthopedic trauma surgeon. So the plus side is this, is that the mortality rate is a lot lower due to the fact that the patients are stabilized when they're coming into her operating room. My next interview was with Dr. Brett Arnaldo. Dr. Arnaldo is the Associate Professor of Surgery in the divisions of Burns and Trauma and Critical Care at Parkland Medical Center. Dr. Arnaldo focuses most of his energy on burn traumas. He told me the story of a 17-year-old that came into the ER with 94% full body burns. He stayed in the ICU for an entire year and then was finally released after multiple reconstructive surgeries. And he'd have to come back for the next few years to get more. 2 years later, he passed away. And at his funeral, half of the church was his family, and the other half was Parkland staff. And that just really goes to show you the personal connections that trauma surgeons make with their patients, and they carry on with them throughout the end. My final interview was with Dr. Brian Williams. Dr. Williams is an Associate Professor of Surgery in the divisions of Burns, Trauma, and Critical Care at Parkland Medical Center. Dr. Williams was actually an aeronautical engineer in the Navy before he decided to be a trauma surgeon. It just goes to show you that when you have that passion inside of you for surgery, there's nothing, it overpowers all else. Upon arriving for my interview with Dr. Williams, he gave me the tour of the entire trauma division, including the operating rooms, the trauma ICU, and the ER. Dr. Williams truly cares about all of his patients, and he was explaining how personal of experience you will get. Trauma surgeons are with people on their worst days, so being able to comfort them, being able to comfort someone who's going through something so horrible is a very big responsibility, but it's also very rewarding. I chose Dr. Williams as my mentor this year because he went above and beyond all my expectations. I know then, as I know now, there is so much that I can learn from him as a surgeon and as a person. I have so far been able to shadow Dr. Williams twice on his 24-hour trauma call days, so this equates to over 16 hours of observation that I've had the privilege to have. So far in my journey, I've had the ability to see an amputation of the lower leg, several laparoscopic colectomies, an umbilical hernia repair, a gunshot wound, a car accident, 2 burn victims, an active seizure post-fall, organ exposure post-colectomy, and a man who was hit by a train. It has been such an adventure, and I've learned so much. The amputation was specifically interesting to me. I always assumed that amputation was performed with a straight horizontal cut. However, that's not the case. If the cut was straight across, the bone would be pressed up against a very small layer of the dermis, and that would cause major complications when attempting to get fitted for a prosthetic, such as death for the skin flap and blood clots. Instead, the cut is made about halfway through, and then the back half of the cut will be lower. So this will allow for the larger portion to be wrapped around and act as a cushion for the bone. After all of my interviews, I began my research into many different aspects of trauma surgery, specifically in combat surgery. So I have known that I've wanted to be a trauma surgeon in the military for a couple of years now, and I wanted to revolve my original work around ways to reduce the mortality rate in the wars overseas. To gain a broader understanding, I researched emergency medicine, combat surgery, and infections such as sepsis that can lead to death. My original work focused mostly on trauma surgery in the combat settings. Combat surgeons carry upwards of 80 pounds of medical equipment on their backs at a time. So when they come across a patient to treat, the time that it takes for them to take their bags off, locate a tourniquet, for example, and apply it, is time that is wasted. And in these high pressure situations, every second counts. I researched the 4 main injuries seen in combat settings, and then looked at the main tools needed to treat each injury. The tools will then be put on a surgical belt for easy access. With 60% of injuries with the highest mortality rate is hemorrhage. Hemorrhage is a very broad term, but encompasses any kind of bleeding, excessive bleeding. The main types of hemorrhage that are seen in combat settings are penetrating wounds to the chest, abdomen, pelvis, and back, and also bullet wounds. No matter the type of injury sustained, the bleeding is the very first thing that needs to be stopped. Most people in an emergency setting experience a class 3 or 4 hemorrhage, and that's where 30 to 40% of the total blood volume is lost. The tools that I designated to treat hemorrhage are a tourniquet, to be applied first to stop the continuation of blood flow to the hemorrhaging area, and surgical gauze, to be applied to the wound after the tourniquet is applied to stop the bleeding. With 33%, tension pneumothorax is the second leading cause for death in combat. A tension pneumothorax is air from either the lungs or an outside source that enters the pleural space that should be occupied by the lung, which can and does lead to collapsed lungs. The tools that I have designated to treat tension pneumothorax are sterilization pads to clean the second intercostal space, a 14-gauge needle to be placed in the second intercostal space along the mid-clavicle line, and surgical tape to hold the needle in place until they can get their bags off and get the rest of the tools for the long-term care. Next, we have airway and ventilation obstruction, with 6% of combat injuries and death. These can be caused by a multitude of things. However, the surgical response is an emergency tracheostomy. The tools needed are an 11-blade scalpel to make the 2 to 3 centimeter vertical incision into the skin and some cutaneous membrane overlaying the chylothyroid membrane, a tracheostomy tube to be inserted between the skin flaps, and a bag valve mask to be inserted into the tip of the tracheostomy tube and to begin ventilation. There were other tools recommended, however, I looked over the procedure and deemed some of them unnecessary in a combat situation. Also, after the bag valve mask and the airways getting ventilated, that's when the more long-term tools would be pulled out. Finally, we have burns, with 5% of combat injuries and death. The burns that occur in the combat setting can either be from fire or chemical burns. Either way, the risk of infection increases the longer that the clothes have to melt onto the skin. Keeping this in mind, the only tool that I deemed immediately necessary for the treatment of burns is scissors. This would allow the surgeon to remove the clothes of the patient and then begin to start treating the wounds. The combat belt will be made up of the tools that are immediately necessary among the most common traumas. They are easily accessible, will allow quicker response time, thus saving lives. Thank you.